So it should be somewhere 15-20 minutes or so we have time for discussion.
Yes, okay, I will keep it short and sharp as much as possible on this. Also to give space for the country examples, if possible, and then for the debate, because I think that's the most important. Thank you to be here. It's always nice to be indeed working with the colleagues from Heidelberg. I've been actively working with Claudia Bijman and with your colleague, with your other colleague. Sorry that I forgot the name now. It skips me in a program on global health governance, more recently in a program on a global health education program on international education on global health between Europe and Iran. So it's good to be in this space. You find me in a very tense time at the moment because a lot is going on global health matters at the moment, especially in relation to negotiations at the World Health Organization for a upcoming pandemic treaty where Germany is very much involved in, and there's a whole debate about vaccine equity and how to get vaccines out to the rest of the world, and in the meantime having to deal with the pandemic, both from preventive as well as let's say more response matter. Indeed, the colleague I was referring to, and now can I forget his name, Albrecht Jan. So how it's good to be in this space. Questions, etc., will follow through the chat. I suggested I'll just present the whole thing, and then we have a debate afterwards, so that you get the whole perspective. I always start my lectures with something, let's say, factual or more actual, and from today that is a report that the G20 meeting from last weekend in Rome actually delivered quite little when it's related to global health matters. The writer here, David Fiddler, he's a global health lawyer. He goes long, he follows long time the pandemic governance and developments of WHO and policies. Basically says that, look, it's quite incredible that even now, 2 years in the pandemic, despite all the language, we can't really commit to real hard ensuring that there is vaccinations everywhere in the world. Also because there's so much conflict of interest involved. And the conflict of interest involved is in relation to intellectual property rights and in relation to interests that companies might have to work with biomedical, with not only vaccines but also diagnostics and treatments, etc. And because the pandemic has shown us that countries have chosen to be quite egoistic, opting for their own domestic security, ensuring that their own population vaccinated first before other parts of the global population, which of course from a pandemic perspective is not the best thing to do, because it can lead to creating a variance of concern, and that we still fail to have like a global plan to deal with it. That's quite, it's not surprising given the politics around it, but it's quite cynical for us working already long in global health. So that's from today. I will share the presentation as well, so you can read yourself. So it just sets the scene for how I look to COVID-19. COVID-19 is in a sense it's a magnifier for existing complex challenges that we have in the world. It's not only a public health problem, but it interacts with other existing problems that are already there, including the effect of the economic recession from 15 years ago, and that will likely be deepened in many places, and that also people at the lower end of the income scale will be much higher impacted by COVID-19 than the middle class and the richer. And then there's a whole analysis as well that the emergence of zoonotic risks and disease like corona is also much related to a planet that is heating and where, let's say, the Anthropocene era also has increased largely the risks for vector-borne diseases and zoonoses. Just to mention the risks, I think WHO made the analysis that from 2030 onward, each year there are 250,000 deaths that can be attributed to climate change. So we have to look at this complexity as a whole, and not only as an isolated viral outbreak, I would say, and this image signifies that somewhat. So also here, inequities are of strategic concern for us in public health, but for if you track in countries, between countries, we see that that especially people that have already comorbidities, people that have lower education, people that have less possibilities to sit like me in this regard, safe in my own working from home on and being isolated in a sense. So the occupational risks, they're not evenly distributed. And I think this is very important when we consider strategies within country and at the global level. So I just looked quickly into the epidemiological situation from today. This is data from the World Health Organization. You can find it on their website. On the right side, you see the development of the pandemic over the last almost 2 years now. The benchmark of 5 million deaths was reached yesterday. So I think that's something to, well, not to be proud of, but it shows how stretched and long this pandemic currently also lasts. It's interesting to see here where the pandemic was at its worst over time. And you really see there, and this is something that I would like to outline for us working in global health, that America and Europe has been hit the hardest by far. While, for instance, Africa and the Western Pacific and also the Eastern Mediterranean, there is, and there might be a lot of underreporting, but that's not where the deaths occurred. That's not where the most severe cases of COVID-19 occurred, and that's an interesting finding that should be that does deserve attention, I would say. And we did that in a article quite early in the epidemic, and this is one of the key messages I would like to provide for today, is that we hear all the time in the media that there is a notion about the world is safe unless everyone is safe, and we need to, everyone is at risk, but that risk is really differentiated, and that risk is also very different across different contexts. So you need to see it as a multiplicity of epidemics And that multiplicity of epidemics really has to do with the demography and the comorbidity in populations. I was already referring to it, and the Lancet calls it, for instance, a syndemic. If you already have, if people are overweighted, if they have diabetes, other chronic problems, if you're immune compromised with HIV/AIDS, for instance, there is a much higher risk, not necessary to catch it, but to develop severe COVID or even die because of the infection. Not to mention even the elderly population in our Western societies. But also, and this was a reflection on from my colleague Wim van Damme, who is based in Kinshasa, is why do we see so little infections in sub-Saharan Africa, or relative little infections in sub-Saharan Africa? And although this pattern has changed since last year, it has something. It has something to do with the population, not only the population density, but also where people live, how households are being constructed, and how ventilation works, for instance. It seems that people are much more at risk in poorly ventilated houses where they are strongly clustered together, rather than people who spend most of the time in an open air setting, for instance. And this here also climatic environments, air pollution, etc., all play a role. And an interesting theory in the African setting and some other places as well is that when children, and I think they did some research in Ethiopia, when children have had parasitic disease or have had other infections, then they are relatively protected against developing COVID-19 symptoms, partly because there's something like an adaptive immunity that is being developed. Now, these are considerations that we wrote down in this paper, and I ask you simply, when you analyze the COVID-19 epidemic in the coming period, just really look into the local context of that epidemic, because it differs a lot, even also within countries. So please don't generalize. Now, to say something about, I always use it for, and I assume that most of you are health students, international health students. For us, it's important as health people to understand that there are political reasons and foreign policy reasons why countries cooperate on health in the first place. We always believe that there is a kind of a cosmopolitan ideal as public health people. We want that everyone has access to vaccines, that health is a human right, etc. But states organize their policies via a different way. They are focused much more on state security, keeping diseases out, ensuring that diseases can't be weaponized. They want to have stability within their borders. So that's one of that explains also why states act the way they act. And this balance between cosmopolitanism and security reasons, we need to understand also to see what the diplomatic space is for countries to take effective actions. There's of course also a whole economic driver that is becoming more and more prominent within global health, simply because health care is one of the biggest economic growth sectors worldwide. And that's, for instance, with the mRNA vaccines, we see now that they are not only being developed for COVID-19, but they can be applied to a lot of other diseases as a kind of a new vaccine platform. So the organizations that have the intellectual property and the rights to develop these further, it's an enormous gold mine. And one needs to organize. So that needs to be taken into consideration when when trying to understand how countries collaborate on this matter. Now, the current, so everyone, and I think not completely rightly so, but there's a lot of focus on vaccine delivery and how they've been rolled out. I assume that many of you follow this in the media, and this is to say that simply it has been very unequal, despite all the big words on health, access to vaccines as a global public good, and the role of COVAX and its mechanism. In lower income countries, still only 10–20% of the population is being vaccinated, and I see it also with my students. There's a lot of let's say hesitancy and distrust in vaccines, because one feels that there is a kind of it's charity but not sincere solidarity that we see in this cooperation. For instance, AstraZeneca was being while it was being first considered an option for vaccination and still is in Western European countries, it became second choice because one saw quite some side effects earlier in the year. So populations advised then, or governments advised, rather to take the mRNA vaccines. But those AstraZeneca vaccines were being sent via the COVAX vaccine mechanism to countries in Africa. But people are not stupid, and they said, look, why should we then take second hand vaccines? And of course, the whole debate is much more nuanced, but I understand that it feeds the vaccine hesitancy. It's also to understand, and this is a slightly older picture, that vaccine diplomacy has been so the international relations and vaccine diplomacy playing on the background influence a lot also how vaccines were available in the world. I come every year in Indonesia for personal reasons, and there all the vaccines available, or the far majority, are from China, and that's also being done to make the trade and foreign policy relations so let's say that the diplomatic part of it plays a big role in the background as well. COVAX at the moment is at about 340 million doses that have been delivered, but they said that at the end of the year they should reach 1 billion doses, but that is far from reality. Okay, let me talk for about 10 minutes still about vaccine development and health systems response that we see, and then I'll hand it over. Just check, yes. So there was this inequities, and Tedros, the Director General from WHO, calls this a moral failure, and there is really something that's been hailed as vaccine apartheid or vaccine nationalism, and the mechanism that is most active in it is not only COVAX, but it's the access to COVID-19 tools accelerator, known as ACT-A, and you see here that it's a collaboration from several global initiatives in collaboration with government, civil society, and industry. And it's also been framed as a super public-private partnership, and it's something that it might become a fixed mechanism. There's a whole debates about how allocation works, why countries only provide donations and aid there, but why they still, via bilateral deals, bypass COVAX for their own benefits. And then, of course, there's a lot of, you understand, there's a lot of interest there from all those individuals involved, including those working in academia and research. And to give you just a perspective, and this links to a paper also that we have written, is that immunization as a WHO and UNICEF hailed that in relation to smallpox eradication and polio eradication, and because funding via WHO and UNICEF and via member states was not sufficient, Gavi and other mechanisms started in 2000 to boost availability and boost demand for vaccines, and have introduce what is known as advanced market commitments, and in that regard ensured that there were new vaccines on the market, especially in places where there was a lot of early childhood diseases, rotavirus, but also the DTP type of diseases that we see. However, that mechanism, it works on market demands. It's not that countries have committed to that. There is not a global agreed framework that says how vaccines need to be delivered in times of a pandemic and also in regular times. There has been several developments. There is the PIP, the Pandemic Influenza Preparedness Framework, that came out of the H1N1 epidemic in 2009, but we see now that that's not working. So that's one of the tasks that right at this moment WHO member states are trying to fulfill in Geneva, and that's to come to a kind of an agreement how to distribute these vaccines with future emergencies. I just want to say about inverse care law is that somehow there is a mechanism that a lot of these policies focus on issues that are not the highest priority. And I think also vaccine development, one can see that principle there as well. Assuming that Lisa Forman will still speak or has spoken as well, I will not talk too much about intellectual property and how that relates and the background of it and how it relates to access to vaccines. There's a whole debate about a waiver of the intellectual property rights that has been supported, that has been initiated by South Africa and India, and that is seen as a possible mechanism to make vaccines available. It will be a political signal. The US even has supported it. The European Union, including Germany, vehemently opposes it because they have so much interest in the intellectual property, and they don't believe it's a useful tool. We can talk, there's a lot of nuances about it, but a lot of the developing countries feel unheard because even during a pandemic, Western countries stick to this intellectual property regime. So the last part that I just would like to introduce to you is even if we think about vaccine coverage, And even if we think about vaccine rollout in countries, we need to think about the underlying health systems that deliver those vaccines. And there is a traditional Tanahashi model of health service coverage. This comes already from 1978, which goes from the, I think the international health students might recognize it, it goes from the affordability up to the acceptability and coverage goal. And we have looked at that for a number of countries in relation to whether they could absorb vaccines at all and how they could be rolled out. So this is just an overview to see that there are stark differences, for instance, between the availability of healthcare personnel in countries. Look at the difference between Guinea and Italy, for instance, or even between Guinea and Peru, or the healthcare expenditure differences. So when a diagnostic or vaccine is introduced in a country, there's huge differences in how those health systems can deal with it. And I think this is often forgotten. These implementation elements are really forgotten when global policies are being made. And it often then leads to medicines or other services not being available or accessible at the local level where they are intended to be. Now, we did this then for vaccines and looked at these different elements, for instance, appropriateness, how to deal with, everyone talks about the rollout and production of mRNA vaccines, but it requires a cold chain, an ultra cold chain, how to organize that, how to administer that, how to get that through rural areas with limited electricity, etc. The affordability of vaccines, when they have to be absorbed by a national budget, can they pay it? For instance, the Pfizer price is between $20 and $30 per doses, and that might be lower for low-income countries, but can a national health expenditure, can they absorb it at all? Or might it push out a lot of other expenses that are required? Then the whole the qualification and regulation elements that needs to be put in place. Yeah, so there's a lot of considerations. We detailed them in this paper. Lastly, there is several reports that talk about what to do next, what matters to make it the last pandemic. This is from the independent panel, and they talk a lot about sharing licenses and technology transfer to have vaccines locally produced. There's a lot of talk about financing international being made available before a pandemic hit, and how to organize it, including then this by now, what shall I call it? Rather, everyone looks a little bit like this. The treaty development, as somebody called it, is like waiting for Godot. It's the Deus ex machina that comes out of the sky that will ensure that everything will be organized. So this is something that is currently being very carefully negotiated. Do we need a pandemic treaty, or can we still work with the international health regulations? The most important thing is that we need a contextualized, comprehensive health systems approach. And this is my main important message, is we should look into that, bottom up, understanding the big policies, but looking really into what is contextual, needed, relevant, and how knowledge sharing and best practices function. So it's about, this is from Yuval Harari. We now have it's a little bit of we are in a momentum where we can really choose to cooperate, and this then also relates to the climate negotiations, or do we decide to be egoistic and let the global fail? So that's really, it is really the moment at the moment to work in global health. I hope this inspires all of you. And lastly, I would like to say that, so this tension between a more biosecurity focused, top-down disease control approach vis-a-vis more comprehensive global health issues, it's an old tension. It exists for a long time. We see it again now with COVID-19. I'm advocating, practicing, teaching, analyzing approaches that are open for more democratic participatory ways. And it's really, I think this is also for the sustainability and to look at the challenges we have. That's the way to approach is intersectoral and really giving space also for other perspectives and viewpoints than the more biomedical Western approaches that we often push through. Okay, I hope this gives inputs for debate. Over to you, Ola. We don't hear you, Ola.
Okay, I think I had my microphone off, did I? Remco, just a quick check. Can you hear me?
Yeah.
Perfect. And hopefully you can see me as well. Sorry for that also to the audience. I would actually say thank you, Remco, for this very thoughtful and at the same time almost depressing talk. Because, you know, I would have always hoped that the international community would have learned out of what we've seen in prior epidemics, where we actually agreed on international health regulations, where we actually thought that we were going to collaborate. And unfortunately, you are underlining very much that COVID-19 has shown us that none of that happened, particularly when it comes to vaccine distribution. I find that quite shocking, particularly on the background on your second talk, Remco, or second part of your talk, where we actually said already since the 2000s, actually, we are really doing pandemic preparedness everywhere with all sorts of different tools. If it is Gavi and vaccine development and distribution, etc. But we failed utterly. So perhaps that is something we discussed yesterday already, and we can get your opinion about that. But I think we should move swiftly on to our next speaker. And I would like to stimulate the audience first to go ahead and try to collect questions in your mind or simply have them ready when we come to question time. Because the layout of this session is that Remco skillfully gave us the sort of meta-level global view of a very sad situation. But our second speaker, and unfortunately our third speaker is still not here, Power Cut and Continue in Peru continues. But our second speaker is actually probably going to tell us very much how that translated to reality, or Remco described on the global scene. Rondemo Kon is a medical doctor by training, and we're delighted to have him here because he has a particular skill to kind of combine all research capacity with local community needs. He not only has extensive background in public health, of course he wouldn't otherwise going to address you now, but he founded an NGO in the very east in Nagaland in India, Community Health Initiative, CHI, where he was actually looking into strengthening primary healthcare services. And I'm sure he's going to tell us about the experience of COVID-19 and how that translated into reality in Nagaland. He was until recently in Nagaland, but at the moment we see him actually in Germany, I suspect somewhere in his room, as everybody does nowadays. But Ron actually won the very prestigious German Chancellor Fellowship. So he's very much related to outgoing Chancellor Angela Merkel via the Humboldt Foundation. And I think we are very happy to have you back in Heidelberg for the next years to come, Ron. The floor is yours.
Good morning, everyone. Thank you so much for giving me this opportunity to speak here today. Um, in continuation with Remco's talk about the global perspective, I would like to go more now into like a country's perspective and even possibly dive down into the local perspective. So my name is Ron, and basically I come from Nagaland, India, and I run a nonprofit called Community Health Initiative. And since last year, I was working as a health consultant for the National Clinical Registry for COVID-19. So this is a government of India run program that was started in September 2020 to basically establish a registry system for pan-India to get the clinical data of COVID-19 patients admitted in the hospitals. So today, my presentation, I would just like to briefly explain what is this registry about. And then through this registry, we also published an article, and I would like to briefly talk about this. So as mentioned earlier, so this registry was established in September 2020. And during the time, it was kind of like started quite late, but there was still a lot of unknown parameters and the virus, how it's affecting the local population, because India is quite diverse and there are a lot of ethnicity, ethnic minorities, race, a lot of demographics that play into this thing. So the government wanted to establish this registry to basically look into how can we get the clinical data to establish a more robust guideline for policy making and also for research questions. So the primary objective of the registry was to collect the data, and also I look into children and adolescents that have been affected by COVID. The secondary objective was also to utilize the data to answer research questions. And as we know that India is also suffering from communicable diseases like TB and other NCDs like malnutrition. So it's kind of like also looking deeper into those diseases and how COVID-19 is affecting them. And also lastly, to collect the follow-up data of patients, which has already begun. So there are 6 times that we follow the data up. So it's like every month after the patient has been discharged, and after that, every 2 months for 3 times after the patient has already given the data. So as for the methodology here, basically I was working in one of the satellite centers, and this satellite center was then monitored by the registry site, which is like, by the way, like all the hospitals that are part of this registry are tertiary care hospitals, and that involved both the public and private hospitals. So basically, I was involved in one of the satellite sites where I collected the data from the hospital and then uploaded into the portal system. So this, after I uploaded in the portal system, then the data was then verified by the registry site. And then also, like, we were provided training from the monitoring committee on, like, for example, recent training was also given to us on verbal autopsy, because as one drawback or challenge that was raised during the COVID-19 pandemic was that most of the patients that died we were not able to identify the exact cause of death after they were discharged on. So we were trained in this verbal autopsy, where we will actually go and then interview the families in person or via telephone, and like with the use of certain tools and methods, identify the exact cause of death. So this study was for 1 year, but now it's kind of like extended for another year. So it is until 2022 September. So basically, the weekly reports, the outcome of the study is to establish weekly reports from ICMR and the ministry. And also there was periodic special reports comprising of more in-depth analysis. For example, the publication that I would be presenting is one of the outcomes. But there are also more publications that are like pending. And the criteria for the hospitals were basically those patients that were like admitted due to COVID, and the exclusion was like that patients that are not admitted because of COVID. So in the satellite site, I was working at the Naga Hospital Authority in Kohima. That is a government-run hospital. That is one of the largest public hospital, and this is accessed by especially the poor and like the marginalized populations. So it's kind of like it's also it's a tertiary hospital, so also accessed by a lot of people. So we were kind of like provided like with certain forms. So in the baseline form, we had to like include the data of all the patients irrespective of their age and race. The health worker risk assessment form was for health workers. The daily form was filled every alternate days for 14 days, or until the patient was discharged or like or the patient died. And in the daily form also, we kind of like included the laboratory parameters. And in the summary form, we included like this medications and also like whether the patient had received oxygen, or and then finally like the outcome of the patient. And healthcare facility related questions, this was like a one-time form for the hospital. And the multi-system inflammatory syndrome, this was for children and adolescents. And finally, the follow-up form, as mentioned earlier, like we did it, like we have to do it for six times. So every month we have to follow up for three times for 3 months, and then after that, after every 2 months, we follow up. So this was a portal site where like we enter our password and the username, and then we add the patient, and then we can also see here that the number of pending forms and submitted forms, and we can also follow up the patients from this portal system. So ethical considerations like ethical approval was done from ICMR, and also the registry sites also contacted the satellite sites, and then the ethical committee gave the approval for the study. So now coming to the second part of the talk, that's the publication that is on the result from this registry, and that is the clinical profile of hospitalized COVID-19 patients in the first and second wave of the pandemic. Insights from an Indian registry-based observational study. So as mentioned earlier, so they are like all together, including the registry and the satellite sites, there are like 41. They're both public and private hospitals. And the registry was based on the hub and spoke model system. And the quality of the data was very rich, because also it took into consideration the pan-India network of hospitals, and except for 1 or 2 states, most of the states were hospitals were like willing to participate in the study. So basically, the stratification, like just going to the next slide, just the stratification of like how the waves was COVID wave affected India. In the first wave, it was from like September to January, and the second wave was from like February to May. So based on this evidence, the registry also kind of like divided the data into these two clusters. So first, the demographic data, as you can see that the highest age group in the first and second wave was between 40 to 60. And for the gender, we could see that the male was much more higher both in the first and the second wave. Some of the clinical characteristics like that had like one or more comorbidities. What was interesting was that in the second wave, the comorbidities was like absent, like I mean less as to the first wave. And the three highest causes of comorbidities was hypertension, diabetes, and chronic cardiac disease. As you can see, these are like NCDs, and India being a developing country, NCDs is also like one of the, like we have this double burden of disease in our country. So this also affects our population, and this was the thing that was also seen in the study. So as for symptoms, we could see that in the first and second wave that in the first wave there was 85.7%, and in the second wave it was 78.3%. The most common symptom was a fever, and in the second wave, as you all also may know, that India had suffered this huge crisis with this oxygen and all these things, and you must be seeing that in the news. So similarly, in our studies, that it also showed that shortness of breath was comparatively higher than the first wave. As for the complications, the highest was in the second wave that was seen was acute respiratory distress syndrome. As you can see, it's like 13% compared to the first wave. And also in the hospital, those patients that had the diabetes, the complications also was seen during the hospital admission. As for the patient outcome, in the second wave, it was the death was higher at 13.3% compared to the first wave at 10.2%, and the discharge was more or less kind of like similar. And the outcome is quite interesting. What we saw is that between the ages of 40 to 60, like there was increase in the second wave, and this could be also the studies show that like there are a lot of complacency in the young people because they wanted to go to work. They had like they also like had to like their jobs and stuff. So like they started to go out. So this could be one of the effects of how the young population got affected. And of course, the vulnerable populations in the second wave was also higher than that in the first wave. As for the treatment, dexamethasone was used higher and compared to the first wave, and methylprednisolone and tocilizumab was also like similar. They were similar use. The oxygen in the first and second wave, we can see that in the second wave, as we saw in the previous chart, that there was a lot of shortness of breath. So in the second wave, it was considerably higher than that of the first wave. And this is my final slide. We can see that the duration of hospital stay in days was in the second wave was 6, and the duration of hospital stay in days in discharged patients was around 7. This could be also because like the doctors were then like getting used to treating the patients, and the outcome was like they knew what kind of about the prognosis of the patient. And finally, the conclusion of the study was that the second wave of the COVID-19 in India was slightly different in presentation to that of the first wave, especially the younger demography was more affected. There was less comorbidities in the second wave. And finally, the presentation of breathlessness was in greater frequency in the second wave. So I'd like to thank you all for the time, and I look forward to the questions.
Well, thank you very much, Ron, for this very interesting talk, and particularly the details of reality or how COVID-19 developed in India. I remember vividly between the first and second wave, if I'm allowed these words, where the Indian government was underlining the successes of COVID-19 control, and then it really hit hard, no? And you can really show it with the numbers, no? Well, I would actually say last try, just to check if Alejandra, where I have the difficulties here with the system, was able to join, but I don't think so. I'm just going to ask help desk here and technical support. Are we getting Alejandra on board? I don't think so, no? Doesn't seem to be the case. I would actually say, Remco and Ron, we both need you here on camera, if that's okay, Remco, so we can actually discuss together. Again, for the audience, we have time for questions, and I think I would actually stimulate everyone to think, to bother Remco in the direction of what can the international community do for next time. I have doubts, Remco, that we are ever going to stop pandemics, but I think to control them better. Ron, we need you on camera as well, if possible. And I would actually stimulate the audience to bother Ron also with questions. How did the entire COVID-19 pandemic hit, particularly the rural population? How was equity being affected? Was there any element of very poor people couldn't really control the epidemic involved or not? But before we go there, only as a stimulation, food for thought, we have a few questions. Remco, you're the first one, if that's okay. So there's a question coming in from Frederick Dundee, who's saying it's a wonderful exposition and presentation. And he says it's ironical that while there's excess vaccines elsewhere with calls for a third dose, other people are somewhere hoping against hopes that they get their first dose. And of course, it makes one wonder, is saying that health threat somewhere is a health threat everywhere more of a cliche? It's weird. And Florian is adding to that immediately, what would be the added value advantage of a treat compared to IHR as a solution? Remco, perhaps an immediate reaction to these sort of very challenging question, and also the solution that Florian is suggesting, perhaps.
Yeah, this is these are key questions, so thank you for asking. It's a health threat somewhere in the world is a health for everyone. That's a political frame, I would say. It's also the emergency frame that is now being used by the EU and others to generate attention for the need to invest in vaccines and other measures. And I think that's often used when there are emergencies. In a state of emergency, you can bypass normal deliberation because something now needs to be done and everybody needs to be safe. But it distracts from me, and this is theories by the German sociologist Ulrich Beck, that risks are differentiated. Risks in general are not equally distributed in the population. You can mitigate risks via insurance, for instance, or via government can do that via social contract or taxation, but risks are not evenly distributed. They're closely linked to inequities and to intersectional positions in society, so that everyone is at risk. Everyone has a differentiated risk, I would say. And this is where the difficulty comes in, because who should be prioritized? Who has then it's about governance, and who is in charge to decide where the priorities are and what not. And in my view, it has been rather skewed towards the biomedical vaccine deliberation that we see now over this more comprehensive public health, let's say, participatory approach. That, I mean, public health is not a new field of, it's not a new discipline. We know since centuries how to deal with pandemics. There are many pandemics. There's still the HIV/AIDS pandemic. There have been influenza pandemics in the past, and these also led to deaths, but we could deal with them as well through distancing, surveillance, basic notions of hygiene and environmental promotion, etc. So I wouldn't argue against vaccines, but there are alternatives as well. And I think this is this is something to be considered. I don't want to be cynical, but it's really, you can be cynical about it, but this is where states also find themselves captured in needing to fulfill politically to the demands of their constituencies, and then there is this demand for a booster shot at the moment. I can understand that. At the same time, from a global pandemic perspective, that doesn't hold in relation to the variants of concern. So then you ask citizens to identify themselves as a cosmopolitan citizen with other people around the world in a polarized political mandate landscape with a lot of hesitancy and distrust in politics. That's very difficult to do that. But I think we as health professionals need to take leadership in this and also argue for that in that regard. It's not only about risks, but also about humanity and having access to essential services, I would say. Now, regarding so we're doing now a research on the international health on the pandemic treaty and whether it's a good idea or not. This will be presented in Geneva on the 24th of November, just before the special session of the World Health Assembly. And we come to the conclusion, I can already hint a little bit to that, or the findings hint to that, is that a pandemic treaty, it might have some, there are elements like vaccine equity issues and addressing One Health issues and more rapid response and generating finance that may make sense, but you can, like, there are many treaties, but it will not, the devil is in the details how they will be implemented. And there are real concerns about how democratic this treaty is being crafted. And it's like there's a big push like, no, we need to do it now, because otherwise there's no momentum, but that might not give sufficient confidence and trust by many developing countries. That's the impression that we got. And from there, we would argue for more slower amendments to the international health regulations, which has been a longer democratically agreed a treaty that's already available. But the EU thinks it's not enough. But that's where the dispute is about at the moment. And the Americans are going for the IHR and the Europeans are pushing for the treaty. geopolitics in life. It's almost like a soap to follow that.
Thank you very much, Remco. And I would add to that soap story that you're saying. On top of that, the way how you said it, sort of is that sadly, the rest of the international players that are not as wealthy as the two sort of regions you just mentioned, apparently, again, sort of are not completely included in the decision-making process. I have a feeling, or I was discussing with a colleague of ours who was actually really prominent in the H1N1 2008, 2009 epidemic, and equally in everything in WHO. And when it comes to pandemic preparedness, very much based on influenza the other day. And we actually simply said, IHR is out of the window, right, in the COVID-19 scenario. And it's very difficult to see how we can actually pick up, in my view, on IHR, where we know that it was not enough as a binding document, because there's no treaty element as such in there, isn't it? Where we think we need to elevate, and that was a bit the discussion yesterday already, where we need to elevate to something more binding, perhaps. And that's where this treaty business comes in, I suspect, a little bit with the pandemic treaty. Do you think, I'm repeating the question here from yesterday almost, do you think we're going to get to any further elements to control such documentation? IHR is voluntary for countries. No, they don't. There's nothing in repercussion if you're not fulfilling IHR regulations. Would it be worth it to link into something that we labeled yesterday, like an international health court or so, if we have a pandemic treatment, or is that exaggerating the case?
Historical analysis in epidemic governance shows that there's always the wish to do more and to have a more of an international regime that can control these outbreaks, but at the same time states then fall back on their state sovereignty. That's the Westphalian system we decided on since 3-4 centuries. Of course, that can be changed, but that tension is always there. I do believe now that the approach that I will take is that there might be new elements that might be negotiated in a new form of treaty. It's unclear what the scope will exactly be, and the IHR will be amended. So they will model through with both options. That seems to be the option taken. The thing is with the treaty, and this is a long debate we have with legal health scholars, if you have a legal law, it doesn't mean that people will follow it. And especially there will be no sanctions in it, because you can't, because it harms international law, and countries, US, China, etc., also will not agree on this. But we seem to think that when we have a law, then things will work. Mm-hmm. But that's also not the case. That's not form follows function. The function is we need to cooperate to get over this pandemic, and we need to show collaboration, and all the tools and the rules and the policy frameworks are there. There's nothing that holds the world to collaborate on COVID-19. There's nothing that holds us against sharing information and vaccines.
Very good response. Also answering comment by Astrid coming in. She actually says IHR is binding. Of course it is. It's binding between all countries in WHO subscribe to it. And I still remember, sort of the headaches that were done until 2005, until we actually had that binding document that all member states in WHO signed at the time. But of course, it's not only implementation. I think there's also, Astrid, and expanding on that, the simple fact that you can have something binding, but if you don't follow, and there's no way how to say, you didn't do it, why? Then however that is going to look like, if it is collaboration, if it is convincing, or anything that goes stricter, then we are running into trouble, as we've seen. So for everyone here in the audience internationally who is not so firm in European history, the Westphalian Treaty actually is really interesting that Remco mentioned, because that was actually for the first time where we had more smaller countries and regions where there was an agreement developing how the boundaries in Europe are going to look like. And we started to have for the first time some sort of nation type of development in the European context. And that actually, in the way how we're collaborating, still has, I wouldn't call it repercussions, but effects on how Europe in many ways is still organized. And I'm saying that only because I'm at my parents' place in Westphalia. So it is actually quite nice that you're referring to that. Right, let's move on perhaps to the situation in India. And Ron, I was very much impressed by the simple fact how you were able now to present the level of detail of COVID-19 surveillance and the data, how the particular, how the epidemic actually hit India. Florian is asking, public health measures differences, or as you presented in the first and second wave, and there were countrywide and very different, probably, sort of pictures in different states in India, if that's correct. And the response was probably also different. How was it accepted by the public? So the first question is, there were probably, was quite a bit of variation in different states. And then secondly, measures were perhaps also different. And how was that thirdly being accepted by population, that there were differences in the response? Tricky question for you, Ron. And perhaps Remco, if you want to comment later on as well on that particular item.
Okay, I'll do my best to answer this. So yeah, like in the first wave, we saw that there was like a lockdown, and before the lockdown, there were a lot of the migrants who were working in one location trying to go to the other. And because of this lockdown, the trains stopped moving, the transportation, you couldn't find anything. So there were a lot of people from the poor strata of the population that were taking, going by foot, or, taking bicycles and, just migrating from one state to the other, As we know, India is a federal state. The states have its own kind of regulations and its own guidelines, especially in terms of health. Every kind of state had its own kind of a way of regulating things. So when the migrants started to come in, in the first wave, a lot of the state, of course, I'm sure the COVID must have already reached, but the migrant people who came from other states to especially in the Northeast, where I come from, the Northeast region, the cases were very low. But a lot of people who were working, employed in other bigger cities like Delhi, Bombay, or Bangalore, they started to come in, because they lost their jobs, they had no work, and they had to come home because that was the only way to be secure. But coming in this group of population also brought in the virus along with this migration. So for me, I see that if you see also the healthcare system, we all know about Kerala. Kerala is it's almost compared to the US in terms of its some of the health indicators. But right now, Kerala is also was one of the hardest hit states in the second wave. So all their healthcare infrastructure was badly hit. And even with this COVID study, when I was doing this COVID study in the hospital, the doctors and the healthcare staff were so overburdened. So when I used to go and try to collect the data, lab parameters and things like this, they sometimes were they were overburdened. My one was another study, and they had another 2-3 studies going along with it. So they were so overburdened with just filling up these forms and stuff, and also so much of pressure from to look at the patients. So I think for me, the challenges in different states was different from like in the first and second wave. But to my experience, to what I saw in my state was also like quite different from what I saw in Delhi, for example, which they had a lot of clusters of population that was like that was positive, and especially with this new variant, the Delta variant. And but one thing that I saw, like from the community perspective, was that there was a lot of community mobilization in terms of raising financial resources, or like trying to help out the people, like especially like crowdfunding. Crowdfunding was something that was so new, like to our community. So a lot of money was raised, especially during the oxygen crisis. So there were a lot of oxygens that were provided, pulse oximeters, you know, like coming in from all directions. Like I never expected this community mobilization to be so strong. So that was seen, like that was the positive aspect that I saw from the community, how they try to mobilize resources within themselves. And my NGO also, like we started this COVID-19 solidarity response project, where we raised some money for providing dry rations for the migrant workers. And especially during the first wave, there was also shortage of PPE suits. So we kind of like locally manufactured for the healthcare workers. So I think the question is a little bit tricky, kind of like divided into two parts. So maybe if there is time, I could answer maybe if there are more questions, or in the coming time, or yeah.
Thanks, Ron. And I think the question was actually also very much derived on the particularities, and even in the German circumstances, where we actually have measures that are completely different in different places, and how that is being acceptable also, right? Because that is a key element. But perhaps, Remco, do you want to comment to the sequence of questions that, or part of it that I bothered Ron with? Thanks, Ron.
Well, on this acceptance, it depends a little bit on which context you would like me to speak. That would be my question.
Context as in which region, area, which country. I think start off with our own experiences here in the European context. Yeah. And then we can perhaps use some of the elements to transfer to our ideas to low and middle income countries.
So I had my personal experience is that last year I spent the most. I spent in lockdown. We had lockdown here, I'm in Berlin at the moment, we had so there was a lockdown in the beginning of the year, and then as a family in Indonesia, I was in July, August period there, and then the pandemic was at its height. So the lockdown there. And now here we slowly see the numbers increasing in Europe again. And we are entering, and so from my personal reaction is I'm somewhat fed up with it, with all of this. And also in relation to priorities, there are other things in life that requires attention. There's no vaccination. So there is this, again, this hierarchy of risks and needs. And I think that is a reaction that many people have, especially the younger populations, whether they should still adhere to public health measures that are being imposed. And if this is not done carefully, and there is a whole debate about the deliberation and the democratic quality of all those measures, there is movements in all countries in Europe that actively oppose the COVID-19 measures. And if we can't really explain why more stringent measures now are again needed, I think there can be quite a severe backlash. So I will be very, in the Netherlands, they announced new measures yesterday. I'll be very cautious in that regard. What can we learn from that from middle income settings? not only through COVID-19, but also in the reaction to other epidemics. And I refer to Ebola, I also refer to the Zika experience in Latin American countries. Also what I saw during the COVID-19 outbreak in Indonesia, there's been a big enforcement of security actors, traditionally not working in health, so police or even military forces who are being given a role in health activities. And that's then being done for the global public good. We need capacity, etc. But there it then also, it has then to come in with distrust in relation to those actors. And we see that in many countries, trust in security forces differs, of course, a lot. There's politics around it. I recall trying to, well, so I give an example in the district where I was working in Indonesia in the past. Military actors in the health personnel have been attacked because during COVID-19 activities, because they were distrusted by the local population, and they saw that there was a dual use of objectives of the military being there. This is a traditional challenge we see in health. There's more attacks against healthcare facilities and personnel. So we need to be very reflective about what is possible and what can be solved in a different way as well, and being as participatory as possible.
Yeah, very interesting, Remco, in your description. Ron, perhaps you expand on that as well, because we've seen in the wealthy countries that, of course, before we had vaccination, public health measures were being suggested and then enforced, particularly, of course, social distancing and mask wearing. The first one being very efficacious and community effective, if you look at it. The second one contributing particularly in combination with other measures, also mask wearing, not superbly efficacious or community effective, but still relying on two things. Firstly, social distancing, that people stay at home and work from home, that the society is enormously wealthy in order to feed everyone. Then secondly, mask wearing, that we simply have the masks available, right? PPE was at the beginning an enormous, personal protective equipment was an enormous bottleneck because of global supply chains. How would that translate to your community in Nagaland, Ron? How feasible are these two public health measures in communities where there is simply less money? And I'm not going so far into the acceptability, but firstly into the question of feasibility.
I think this is, it was a challenge in the first, in the beginning part, there was a challenge because there was lack of awareness about actually what the disease is all about. They didn't know, like for instance, when I was working in the hospital, the people were they were decline in a number of other kind of vaccinations also, and also other outpatient treatment. And because people were basically, they didn't know about the disease and they were saying that they are scared to go to the hospital for any kind of treatment. So the thing was, there was lack of awareness. And most importantly, there was stigma, because people who were infected by this COVID, they kind of they didn't even tell that they have COVID, you know, because earlier time I remember in the first wave, they were putting some kind of play cards that this is like a COVID infected house or like that, you know, and there's people quarantining like this, you know. So people were not allowing this to put, and there was also a lot of in the community, in the local colonies and wards. They were they had this own council and leaders, and they just locked themselves up, like no one was allowed to go out and no one was allowed to come in. So even their own community members were not allowed to go in. But that being said, people really saw the effects of the second wave. They saw that people were dying. They saw it was in the news. They saw people, their own families being affected. And actually the mask wearing and social distancing started to be more present from January, more like January, February onwards. And in terms of the vaccination coverage was very low at the beginning when there were vaccines available. Also, there was a lot of vaccine hesitancy in the communities.
Mm-hmm.
But the government and the communities, the civil society, there was a lot of mobilization, especially towards addressing faith-based organizations. Also, they worked together. In saying that, okay, this works, So it was very surprising to see also some villages was 100% they vaccinated the villages, and there's some villages not 50, 60, but the vaccination rate in Nagaland is actually very high.
Mm.
The vaccination rate is very high because they involve all the other stakeholders. So it was not just the government saying, okay, you need to vaccinate this, but it was the civil society, the NGOs, the schools. They were all kind of spreading the awareness within the community. Yeah.
Thanks for that. Very nice to underline that the community actions are particularly necessary. That even in the situations that you described, where the first initial public health measures were difficult to implement, but even when vaccine arrived, there was a behavioral element in there where hesitancy is really high. And I suspect as well, vaccine hesitancy would be far less if we had a pandemic with a really high case fatality rate. Then people would sort of be much easier accessing all measures. And this is of course not the case, no? So very interesting. I actually thought Alejandra is here. I don't know if she now dropped out again. She was briefly here only because of electricity issues where she is. And she was saying hello, at least, for everyone here in the audience. And she would have loved to be here, but I thought to give her quickly the opportunity to address the audience, but I think she dropped out again from what I see. She was saying she was only on the mobile phone. Apologies for that. I would actually say we are having almost no more question here. There's only one comment here, and that is how binding are the IHR, the international health regulations, can it be disregarded at will in implementation without any cost and penalty? And perhaps Remco and Ron, we are going to discuss that a little. I actually recommend to go that for everyone here in the audience that you actually download the 205 international health regulations. It's a very nice WHO website actually for not only the explanations about the documentation, but also for the implementation. I would almost summarize the following, if that's okay. I'm not an international law expert, and Remco, we need your help a bit more here. But what it is, yes, it's being labeled legally binding. In 205, all member states actually subscribed to the international health regulations and sort of said they were all going to implement that. That is being enforced via a focal point in each country. So there's an IHR focal point, and all countries are working towards that. But what does it mean legally binding? Legally binding doesn't mean that if you don't follow as a country, that there are any sort of repercussions apart from that your international health regulation focal point is going to discuss with WHO regularly why not and what can be done better. And that, of course, for the implementation side is an issue. There is, of course, also, one has to say, a follow-up, and they are, funny enough, most indicators that are being set for the international health regulations are being met regularly by most countries. So people do follow up, and you can then ask, why was it actually not then followed through in the COVID-19 scenario, and that I think we discussed in the last couple of days at length in different sessions. So that perhaps helps to the question. But any reaction to that, Remco and Ron?
Yeah, I discussed this with I'm not a lawyer by background either, and the lawyer's answers to this question is, when I asked it, said, do you know an international treaty that is being that has sanction mechanisms involved in it? There's very little, even also in the environmental field, there is not. That's a problem we now have during the COP26. How can we ensure that countries basically follow that legally binding agreement that they made in 2015? There is in the World Trade Organization, trade rules are binding, and then there are sanctions, interestingly enough, but that is really related to the trade disputes that can occur. There are other international courts, I think, on marine conventions, etc., but also in relation to the more, let's say, genocide and when there is a label genocide involved and gross human rights violations, then international criminal courts can be erected. Realize that this whole international legal field is very polarized. The world is governed through state sovereignty. It's enshrined in international law. If the state wants to meddle in the affairs of another state, then it needs to have very legitimate reasons to do so. And in the recent past, there has been principles like what is called the responsibility to protect, where there could be humanitarian interventions to protect people during a famine, for instance, or when there was gross violence from a country against part of the population. But that has been very politicized as well, and that, like, for instance, the intervention in Iraq or in Libya has been framed as responsibility to protect. So countries now are very reluctant to use that to intervene in other countries. So they rather want to incentivize and you can have a kind of a review. The idea is to have a kind of a review committee to what extent countries implement the IHR, and then there's a kind of it's like a peer review mechanism almost from how countries function. That's the way they want to do it. Is it problematic? Yes, because state sovereignty in the 21st century is really a problem, given the complex challenges that we have. But that's a bigger issue that we can't solve necessarily in the public health field ourselves.
Fully agree to that. Ron, any comments from Indian knowledge of IHR implementation and what that plays as a role in India?
Not at the moment.
Okay, perfect. We don't have any more questions. Remco, earlier on in a very quick coordination meeting, we suggested the following, because we're already on day 2, and we only have 45 minutes for the lunch break for our audience here. And we thought if there were no more questions around 12:30, then we're going to cut it short, that everybody has 1 hour lunch break, which I think in electronic delivery is actually a good thing to do. If you both agree, and there are no more questions in the audience from what I figure, then I would actually say, with the rights of the chair here, I'm going to do 2 things. I'm going to call it a day, and I'm going to thank you deeply, Remco and Ron, for your contributions. We would have loved to have Alejandra here, because we would have seen the input, particularly from very poor population in the Amazon and Peru, on the very similar question. But I think what I clearly realized right now, Remco, on your sort of talk, is what we've seen and dealt with yesterday already. We somehow, and Astrid and I think Fred, for your questions on IHR again, thank you. I would like to say we need to question the legally binding mechanism of IHR. How binding is it? As we kind of, sort of very much exposed here. and where we need to think what can we do. And that was already a little bit the result that we had yesterday in the discussion with Lisa Foreman. Now, Ron, I'm particularly grateful for this very detailed surveillance sort of result that you presented from India, because we've seen two things with that. You used the term developing country at some stage, you know, that we try not to use it in Heidelberg, as you know. We always like to go on LMICs because it showed as well that your surveillance system is actually fairly developed, right? Nowadays, very good indeed. As a matter of fact, we are seeing a completely different world right now. Also, what we've seen from the different waves and how it affected different communities, very interesting to see in India. Luckily, I think I learned as well for the Indian response that vaccine is now available in India. And that, you know, sort of is an enormous advantage for other countries in the world, even very much poorer than India. Then we would not have had that particular sort of result that you showed, neither on surveillance nor on vaccine availability. And there is our equity argument again. I think with that, actually, we are almost leading into the afternoon session, which is called Global Strategies and Preventive, which is going to look with a very interesting panel into very similar questions then that you're going to see in the afternoon. I would actually say lunch break now for 1:30, and I would say let's close the shop and enjoy lunch if everybody else here on the panel agrees.